صباح الخير، السلام عليكم. دكتور عمر، دكتور أسامة.
Cranial. Do more cranial, please. You can. That's fine. Okay. Good. Bye. Okay.
So, Dr. Omar, Dr. Osama, can you hear?
Okay.
You can
Yeah, that's خلاص. We did the IFR.
We did the IFR.
طيب بسم الله. So now we'll go ahead with the
Get the
LAO caudal.
get the straight caudal to give you the best shot.
Okay, it's okay. I usually do LAO caudal. It's okay.
LAO caudal, whatever.
And then we'll do the
دكتور عمر، دكتور أسامة، صباح الخير. السلام عليكم.
اوكي خلاص
بسم الله.
خذ منه.
هتروح ال دي الاول
عشان اي بس.
اوكي.
سماعة تسمعوني يا اخواني؟ السلام عليكم.
طيب let's go cranial please.
السلام عليكم.
يا
عمر، أسامة،
اي بس يا
دكاترة.
محمد.
طيب it's they're working on this is LAD, no? Yeah.
Okay.
Omar,
Just to
Osama,
check.
can you hear us? Can you hear me? شوف
I think
الكوميونيكيشن.
ask audiovisual to communicate with the audiovisual there.
Huh?
They
Bismillah.
can't hear them.
Right.
It's the
We'll get this
audiovisual.
here.
They're not connecting them.
They're
And
not
we'll give you
connected?
the needle as well.
The audiovisual, they not.
Yeah,
connect
Omar,
the
Omar,
the
can you
voice
hear
with
us?
them.
دكتور عمر، دكتور أسامة، السلام عليكم.
في حاجة في الراديو حكاية ال
ايوه ايوه يعني I hate it for that.
ايوه
طيب يا اخواني, we
cannot
have
do-
this is the panelist here. I just discussed this case. We have
طيب,
I don't know how old is the patient, but
go
it
ahead.
seems that we have instant stenosis of OM, yeah, and possibly it's a bifurcation 001, or I mean 0 or 011. I'm not
010
sure.
live already?
عليكم السلام دكتور أسامة السيد
الحمد
والدكتور
لله.
عمر الأمين.
عمر,
أهلا وسهلا بك.
Osama,
I'm not able to hear the.
Yes sir.
I'm not able to hear.
I don't know if they
You cannot hear
Not
Omar?
able to hear.
Okay.
No.
Yes sir, I hear you.
طيب,
Yes.
so we have a LAD according to them, or
We
according
have
to
a-
what we see here, maybe intermediate, we don't know. And we
I
have
can hear
an
Dr.
instant
Osama, but I
stenosis
cannot
OM.
hear the
Adil.
group in Dubai.
Your
Yes.
approach.
Yeah, so as I think, as far as I remember, this is a gentleman who had a borderline LAD lesion that had done physiological
maybe
study by
here,
FFR.
And go ahead with
and
the
was
case
positive.
first, and then we
And I
can
think also 1
move
year
together.
ago, he has an OM stent. And as far as I remember, there is an OM and then there's a circumference.
I still can't hear them unless. Is anybody talking on the other side?
Osteum for the OM1 at that time. The result was good after the first procedure. Now the patient coming with this borderline LAD disease and ISR at the ostium of this OM1 stent.
You need to change the mic.
So basically, maybe I'll do the same that they did. I'll do the FFR for the LAD, and then
No, I'm
just
okay.
assess the
I'm
OM1.
okay. I'm here.
Maybe I'll use
Okay,
imaging just to
I
be
can hear
sure
Dr.
what
Osama, but I
happened to
can't
that
hear
OM
anybody else.
stent, because there's ISR now. And my interpretation that most likely, I think what happened in this case, that there is geometric miss of the OM ostium. And that's why the patient's coming with ISR. But I would like to see the IVAS images for that and just to confirm.
Okay, Waqar, imaging for instant.
I need somebody to talk. I can't. I can't
It's
tell.
absolutely mandatory because you want to know the mechanism. Is it intimal hyperplasia? Is it stent contraction? Or is it undersizing, underexpansion?
Omar, Osama, can you hear us?
Yes.
No.
I don't. I'm still not able to. Can you just change my mic, maybe?
And where is the DCB in terms of instant stenosis? What literature say nowadays?
So the literature is a mixed bag. I think the last 10 years there was a lot of observational trial and data pulled from registries regarding the use of DCB versus POBA, basically plain old balloon angioplasty. And the literature was suggestive at the time that, and still, that DCB is better or superior even to just POBA in those patients. But when the question comes with regard to DCB versus drug-eluting stent, retreating, I think here you have to make a clear distinction what's the mechanism, and this is where imaging comes very handy. If you have somebody who has mechanical problem, the stent is not well expanded, it's undersized, I think adding a layer of stent is always going to be a problem.
Okay, we'll come back to you, Abdurrahman. Osama and Omar, can you hear us?
Yes, I can hear you clearly.
Excellent, thank you very much. Good morning.
Yes.
So with me here,
Good morning
we
to
have
you
a
all.
panelist already, you know them, Abdurrahman Al-Qahtani, Adil Jabri, Muhammad Turki, Nabil Ismail, and Waqar Ahmed, and myself, Abdullah Shahab. Can you introduce your team and the patient and just take us through, please?
Sure. Yes. Well, good morning, everybody. We're delighted to be with you today, and we thank you for the invitation. We have an excellent team with us today in the cath lab. Dr. Osama Saeed, our senior interventional cardiologist, is assisting me in this case today. And we have as a radiographer, Mr. Sam, and our nurses, we have Amira and Falwa, and we also have our scrub nurse, Mohammed Al-Malki, right next to us here. On the outside, there is Mr. Majid doing the CVT job and helping us, inshallah, with the IVUS and so on. So this is our team for today, inshallah. We're looking forward to being with you in this case. Looking forward to an interesting discussion with the group and hopefully a successful intervention. So we're ready to start whenever you guys are. If you'd like, we can start with presenting the case, or if you have anything else that would like us to start with, we'll be happy to do that.
Just please take us step by step through the case.
All right, let's display the slides, please, for the group. All right, so our patient today is a 71-year-old male. Can I go to the next slide, please? That went a bit too far, yeah. Let's go back, please.
One slide, please.
No, go back. Yes, thank you. So this is a 71-year-old male with a known history of coronary artery disease in the past. He's had stenting back in 2013 and 2014 when he presented with acute coronary syndrome outside this hospital. Since then, he hasn't had any further events or admissions. He's also diabetic, hypertensive, and his end-stage renal disease started on dialysis earlier this year. He also has duodenal angiodysplasia, sorry, and he had actually a recent episode of melena, and that was treated endoscopically, so the bleeding was able to be controlled. Now, he presented initially for renal transplant workup to our nephrology team, and then he was referred to us for coronary angiography as part of his pre-transplant risk stratification based on his history of coronary disease and multiple risk factors. So we saw him last week in the outpatient same-day procedure unit, and we did the diagnostic coronary angiography. Next, please. All right, here is the angiography. If you notice, we have a borderline lesion in that LAD, in the proximal to mid LAD, right at the septal takeoff, and it seems otherwise okay. The circ I'll show you in a few minutes, but this is the LAD lesion. I just wanted to focus on it in that proximal to mid portion, and it's kind of borderline angiographically. The RCA is non-dominant, and can you play the next image, please? And this is the focus on the OM, and it's a real osteal lesion right at the takeoff of the first principal obtuse marginal branch. Can you loop that, please? And basically, it's an instant restenosis. Can you loop that last image, please? Can we have them loop the last image? Sam, can you ask them to loop the last image? Yes, please. Thank you. All right, there it is. I just wanted to make sure that everybody can see it clearly. The osteal obtuse marginal, it's a decent sized vessel, probably 2.5 to 3.0 at least. And it's an osteal region, truly osteal. It's an instant restenosis as well. Okay, so with that information available to us, my question to the panel and the group is what should we do based on these findings? Next slide, please. So we have a few options. Option number one would be to proceed with renal transplant after optimizing medical therapy without need for intervention based on the fact that he's got an intermediate looking lesion on his LAD, not too sure it's significant, and just an ostial OM, not a major branch. Option number two would be to perform PCI of the obtuse marginal and treat the LAD medically. And option number three would be to perform PCI of both LAD and obtuse marginal. And finally, option number four, to interrogate the LAD further to assess physiological significance and then decide accordingly. So wanted to get the impression of the panelists and maybe the rest of the people.
So Nabil and Mohammed, based on the preoperative latest guidelines, American and European, these cases, do you need to intervene before they proceed for the renal transplant, or you can treat them medically? If you're going to treat them interventionally, since this is going to be intervention, how is going to be your approach? Patient's got duodenal melena and all that, and patient is, high risk of bleeding.
So,
Mohammed and Nabil.
So I'm actually an insider, so I know about the case. I'm actually from King Faisal, Jeddah. So basically, we have a very active renal transplant program. And our protocol is to be proactive in terms of revascularization, because we know that there is not much of evidence to do that before transplant in preventing future events. However, we have seen a few cases where patients, after the transplant has happened, they come in with an acute coronary syndrome, and then exposing that precious kidney for a contrast at that time is a challenge, is a major challenge that we are facing with our patients. And sometimes some of the patients would be very resistant to go to the cath lab after they get their transplanted kidney. So for these kind of patients, we do the physiologic assessment, and if it's positive, then we revascularize them. That's what we do in our hospital.
I agree with Dr. Nabil. This is our practice as well. I would use physiology for the LAD, and if the LAD is significant, then I would go ahead and treat it. And since the patient is going to be on DAPT for that duration, I would go ahead with the OM-PCI as well. So I would go with option 4, interrogate the LAD first, and then decide on a plan on what to do next.
Any of panelists differ? Any opinion? Any more? Abdurrahman?
So I think this patient, since he's going for a renal transplant, the real question becomes, estimating the risk of future events. Like in those lesions, how would you estimate that? And I think physiology or imaging could help or guide you in this situation. But I think the real question comes in this situation is, like, what is the commitment of your dual antiplatelet that you're going to be considering? And if you are going to commit this patient to a dual antiplatelet, how much you're going to delay their renal transplant? Or would you consider a different approach to shorten the duration of DAPT, or would you use your conventional treatment? I think those are the legitimate questions that should be raised in such cases like this one.
Okay. Tayyip, take us through.
Okay, excellent discussion. Thank you guys very much for the feedback, and I think we're all on the same line. Basically, the decision at that point in time was to interrogate the LAD. If the LAD was to be significant, then we will proceed. Otherwise, we could have held off. So we went ahead and did the LAD IFR, and we'll show you the image next. Can you go to the next one, please? Show us the IFR. Excellent. So that's what we had with the IFR on pullback. It was significant, 0.76. And we had a nice step up or jump up at the level of that lesion, which we saw earlier. So that confirmed the physiological significance of that lesion. So based on that, I guess the next question would be, okay, now what should we do? Option number one would be to perform PCI of the LAD only, leave that OM, it's a branch vessel. Option number two, perform PCI of the LAD and IFR of the OM, then decide. Option number three, perform PCI of the LAD and OM to minimize the chance of future exposure to contrast media in transplanted kidney, because we're going to do the PCI of the LAD anyway in dual antiplatelet, like Dr. Nabil had mentioned earlier. So what would the panel decide based on this finding?
So Waqar, you guys put a consensus paper on imaging and physiology in Saudi Arabia. What does IFR 0.76 mean to you? And do you think that's the reason for patient's intervention, or you think the OM? Just take us through this one as well.
Good question. IFR of 0.76, while is significant, the pattern they just showed shows a more diffuse pattern. I didn't see a very focal step up. I saw, essentially, if Ziad Ali was here, he would tell you that this is very much a diffuse pattern. So I'm not sure where you will start and where you will stop. If the patient is symptomatic, I would definitely treat this patient. But if this is only for renal transplant, I would probably just take care of the instant restenosis with the drug-eluting balloon, and then I don't have to have long-term dual antiplatelet therapy.
Show of hand, who will treat LAD based on this? Raise your hand. The rest will do what? Medically? Yes? What do you do? I said, who intervened? Raise your hand. Still minority. The rest do what? Huh? Pray. Yes, go. Fadal.
Okay, so I think maybe we can display that FFR one more time. I think there's a combination. There is initially a gradual increase that goes with this, the diffuse disease process, but there's also a step up. If you're going to go back, no, go back, please. Yes, right here. So there's a gradual, increase, but then you see a little bit of a step up there. Are we on the same page, or is that not really what people are seeing?
We'll take a comment from Adil. Go ahead.
We need to know what the GFR of the transplanted kidney.
End stage renal failure.
End
stage. Yeah.
So
he's going for
literature
transplant.
says that the transplanted kidney has the same risk like anyone else, maybe slightly more, very slightly more. So now you're treating somebody with no evidence, so that in the future he might need something. You know what I mean? So we don't have solid evidence that he needs treatment. You might treat him like anyone else if he's symptomatic. So if he's symptomatic, sure, he needs treatment for the symptoms. But we know that your treatment is not going to change the outcome in terms of reducing MI. But yet, your rationalization for treating is that I want to prevent MI. Yeah. But we know that treatment does not prevent MI.
Yes, well understood. So basically what Adil tried to say, in CCS cases, based on all evidence, is try to improve the symptoms. Yes, that's what I tried to say. And if you want to try to improve the symptoms in patients who are at very high risk of bleeding and then antiplatelets, try to do your best to reserve the vasomotor of that lesion.
Dr. Shahab, I think it's not only that. It's not just because you want to prevent. This patient is going through a major surgery. So this is actually to consider, if you believe that his preoperative risk is high in this situation, that change your algorithm. So if you believe the literature on, for example, preoperative intervention to reduce preoperative MI and mortality, etc., that's one of the things like pre-op clearance for those patients. So it's a major surgery. So then you have to, it's not only about the future in this situation, it's not about the future.
CARP trial clearly showed.
Yeah, I totally agree. So the CARP trial, but those patients, if you intervene on them, either though they were vascular surgery, if you intervene them or you don't change the outcomes.
Correct.
But in those situations, if you do want to transplant, the anesthesia themselves, they will not clear a patient like this if they have significant coronary artery disease, based on you already confirmed this, to go undergo a major surgery like this.
Then you educate the anesthetist.
Okay,
the other thing is just to consider.
So what's next after seeing the physiology?
Nice discussion. So
imaging, or
I think
you will go ahead and treat that?
Yeah, we will do imaging just to confirm again, and maybe take it as a tiebreaker.
Say it again.
Can you hear me?
Again, Omar.
Okay, can you hear me now?
Yes.
Are you able to hear me now? Okay, good. So basically, again, can you increase the volume, guys?
Raise the volume. Who's in charge of volume here? Yalla, say it again.
All right. Are you able to hear me now? Is it better?
Yes.
Okay. So one thing about that lesion is that it's really in that, proximal LAD area or zone, and that has its own prognostic implications as well. And again, our plan today is to address it using a DCB only approach. So hopefully, hopefully at least will cause no harm. And we can also assess the IFR, FFR post-procedure as well, confirm if it's decreased or not. I think we are agreeing on the OM. I think it's significant and we can proceed with that. The fact that the patient is asymptomatic, he did not really undergo stress testing. So we didn't really push him out all the way to the end to see his exercise tolerance and capacity. So that is kind of a yes and no. It is a stable ischemic coronary disease. Even if he does have a positive stress test, yes, it's a chronic coronary syndrome, not an acute coronary syndrome. And I agree, we don't do stenting to prevent ACS. Stents don't do that. But if you go with the FAME2 trial, you have grounds to intervene based on IFR or physiological significance. It is a significant vessel in terms of its prognostication, being in the prox LAD, and that was what we're based our decision on. So if that's okay with the panelists, we'll go ahead and proceed with our IVUS imaging, and that will give us further insight. Hopefully, that can act as a tiebreaker as well. Okay, so let's get some nitro, please.
While they're working, can I ask the panelists, is there any crosstalk between LAD and OM severely stenosis here? You think maybe what you're getting is not an actual ischemia from LADs, maybe OM is contributing to that? Severely stenosis OM, no? There's not crosstalk?
Just Abdullah, I'll add to
100?
Dr. Adil. I would agree with him. Like stable coronary disease, usually there is, especially in this kind of population, we don't have evidence about revascularization. I would agree the only reason because we have a lot of this dilemma with the surgeon, with the anesthesia always, and patient usually asymptomatic, we screen them for liver transplant, kidney transplant, and we find this diffuse coronary disease, what to do next. So sometimes if there's focal stenosis, proximal, prognostic lesion, we go ahead. Distal, diffuse, we leave it medical. But sometimes we have a lot of difficulty convincing the surgeon and the nephrologist and anesthesia to take this patient. So unfortunately, we end up with complete revascularization. So this is always the dilemma. We try to convince people, like there is no evidence, but still, despite that, usually this is what we are doing.
Yeah. So we want to make life simple. If you intervene and then the patient delays transplant, it's not a good idea. Or you treat patient optimally, with the anti-ischemia, anti-angina, then go for transplant, then you can do intervention. But in the balance, you need to decide appropriately for patient in your mind. So this we're seeing IVUS now. Somebody want to comment?
Right, this is the IVUS.
Oh, okay, yeah.
So let's start the pullback. So we're going to start the pullback right now. Okay, let me just give me a second. This is a tight area. This is the lesion. This is the diseased area right here. There's a lot of calcium and just proximal to that lesion. And we're pulling back. That's a prox LAD right there. And we're going to come to the
do you have pointer?
Circumferential superficial calcium. Okay. And that will back to the left main rod. Okay, stop there, please. Okay, so we can review the IVUS together.
Pointer.
Okay, let's get a distal reference, please. Stop right there.
I love imaging, but most of the time I don't understand what's happening because it's nice to people to see what's. Maybe I ask Waqar to show us. Many pointers too.
Right, this is the mid LAD. Can you go up further, Majid? Just try to get an area where we have as least black as possible. Okay, that may be a bit more further. Go up a bit more. Okay. All right. Okay. Yeah, that's keep going up all the way. Let's see. Okay. Yeah, here may be a good one. Good. Okay. So that's our mid LAD reference. Okay. Now it is a diffuse disease vessel, like we've noted earlier. And on top of that, there is more tight lesions proximally. So our distal reference in the mid LAD giving us an area of 6.3 millimeters squared, about a 3.0 vessel, 2.7 by 3.1. All right, so let's play that and let's move more proximally. And we'll stop at the height of the area of the tightest lesion.
That's calcium.
I think that was it. I think that was it. So go back up.
Right here. That's calcium.
Keep going.
Eccentric calcium here.
Yep. And go up a bit more, please. Majid. Yeah. Go up. Yep. Up a bit more. I think we're a bit more distal. Yeah. Keep going. Show your command. The tightest area. Just want to get the tightest area so we can get the MLA. Okay, somewhere about there. Maybe just a few more. Scroll it up a bit more. Okay. Yep. Maybe here. Okay. Let's get an MLA here. Can you measure that? Do the auto measurement. Okay. So the blue one is off, of course. Type the MLA here is about 4.1 millimeters squared. Okay, that's I think the tightest area, and I think it's a reasonable assessment. What do you guys think, Dr. Waqar? What do you think of this one?
You're still in the mid LED, right?
Yeah, I'm in the mid LED.
So 4.5 would
That's
be
a
for
4.
proximal LED. We don't have numbers for 4.1, so it still looks pretty much
Type.
borderline.
Let's keep coming back. Let's keep coming back. Plate. Let's plate. There you go. Circumferential calcium over there. I think that's Prox LED right here, and we're now approaching the ostial LAD. It's pretty big.
So you
So
see,
between your two markers, you have what appears to be a focal lesion. I'm pointing it out to our audience here, right there from the first calcium. I'll tell you when. Wait. Hey, we'll start here, and
Okay,
then
start here. Okay, stop here.
Now go back a little bit.
Go back up.
Go back. This is what I used to tell my text, but now I do it myself. Go back.
Go back up, I imagine.
Go back.
Keep going.
Go back.
Keep
Yeah,
going.
probably start here.
Here.
Start here,
Okay,
right
start
there.
here.
Yeah. Yes. And then
Yeah.
from here until where the calcium ends would be your stent length.
Yeah, we didn't do an automated
balloon,
pullback, so
or
it's going to have to be
whatever,
estimated.
Your balloon
Yeah.
preparation.
No, I mean,
and
we're going to have to
خرب علم
estimate the
الموضوع
length.
كله.
Yeah.
Just one question here. Do you really need to treat this lesion? This is diffuse disease, FFRY, like diffuse, nothing focal. Is there like even a landing zone? Because this is calcified vessel, you know, need maybe preparation, you'll end up with dissection, maybe you end up with stenting, you don't know where to land.
If you prepare this and you put a DEB, you may get it.
let's discuss your debulking devices here. Just quick one. Start from.
So I think for debulking, this is about 180 to 270 degree of calcification. I would go with a cutting or scoring balloon first, just to be cost effective. And then depending whether I get the calcium modification I want, I might further escalate. But I would start with that first. But I agree with my colleagues, maybe looking at the IVUS, I'm leaning more towards a conservative therapy for the LAD rather than proceeding with ballooning or stenting for this lesion.
Right. We are now away from medical, so we need to go intervention. I want to know debulking at Qahtani. Any other devices you want to use?
If I'm interfering on this lesion, definitely starting with a cutting balloon if it's not lithotripsy. This is almost 360. So you wouldn't prepare
Cutting
the lesion.
and lithotripsy.
And if it doesn't work, shockwave, IVL.
What's the difference between the two?
Oh, so
Based on the latest trial, any difference between the two?
So there's no difference between the two, but if you have a thin calcium layer, less like 0.3 to 0.5, you might get away
So
with.
what do you
with
saw?
cutting.
Do you think you need IVL here?
I can't look behind me.
Right here.
Yeah, show us. There is an area of 360, but it's not thick, it's thin. So I think cutting balloon will work.
Go with a
but if
simple
it
one.
doesn't work, in case, then IVL should be the way to prepare this patient.
So all agree? Going with that kind of device, yeah? Yeah, let's see how you handle that.
Okay, if I may add something, my personal preference may be more towards IVL. The reason being, I want to try and minimize the possibility of significant dissections with a cutting balloon, even though dissection is part of the treatment. But I think it gives me a more, like predictable breaking of the calcium. It's a diffuse long lesion. There are multiple areas a few areas of more focal stenosis. So angiographically, it may be more apparent, the area that we need to treat. And I think one good dilation with maybe a lithotripsy balloon might save me all that cutting and all that
Let's
stuff.
see the action.
If that's okay with
Now
the
we have
panel?
limited
Yeah,
time.
okay. Okay, let's go ahead. Let's proceed with that, please. Can I get a lithotripsy balloon? Give me a 2.5. Give me a 2.5. We'll start with a 2.5.
If you have any questions, comments, please come to the microphone and say what you want to say. Don't keep it inside. Huh?
Would you like to use one-to-one for the lithotripsy balloon, or just because the size of the LED is bigger than?
Yeah, I might use two. I might use a 2.5 more distal and then a 3.0 more proximal. I'll probably do that. It is more closer to a 3.0 size. So I'm just concerned about, the bulkiness of the balloon and whether it's going to go through or not. But yes, absolutely. I do like to use one-to-one. Start off with this one first and then see if we can get a 3.0.
So you choose your balloon based on angio or IVUS?
Of course, IVUS would be better. It's more accurate.
I'll go with IVUS. IVUS is more accurate, more than angio.
Yeah.
Usually, angios sometimes underestimate the vessel diameter.
No, for this, if you want to go DCB, do you choose it based on your IVUS or angio? In your practice, I'm asking, not what should be, or your practice. What do you do?
If I do IVUS, I'll go with IVUS.
Yeah. Okay.
Me, it's part of the optimization of the interventions. We have access to it
Yes.
for long term.
So what balloon are we using here?
Using the shockwave balloon.
Shockwave
We're using a 2.5 to start with. Yep, we're starting with a 2.5 first.
So normally, IVL balloon go through easily. No need to do any preparation.
In this case, I think it should pass, but sometimes it needs preparation first because it is a difficult balloon to cross. But I don't think in this case should be any problem.
How, Rahman, how IVL works? What size do we have, and how should we use it, handle it?
So those balloons tend to be a slightly bulkier than your usual size. So if you're looking at 2.5 and you go up, escalate up, it will be bulkier than 2.5. So if this goes, fine. If it doesn't go, then sometime you need to prepare for it. It works by emitting ultrasonic waves that basically send disruption through the calcium plaques, leading to its crack. It's safer than your usual atherectomy devices. And I think in the future, it will be the first line management.
Can you see the angio while you're doing this, please? Can we see the angio? Remove
Yes,
this
we're going to get the angio right now.
Remove that, yes.
Yeah, okay.
So was it easy to go?
So we're
there?
able to get the balloon. It went. A little bit of a push, but it went. Go ahead. Let's take a cine here, see where we're at. So I think that's where I'm going to be aiming for. And then if it works well, I'll take a 3.0 a bit right there, a bit more proximal. So we'll start over here. Let's go up on the balloon.
What pressure we go?
So usually we go to 4 atmosphere, deliver the shock wave, then go to 6 for 10 seconds, then deflate.
Right.
Agree. Yeah, let's go up. All right, going up to 4 atmospheres right now.
Quickly for the audience,
And
this is not the emitters, this is just the balloon. In between there are 2 emitters. They are the ones that are sending the shock waves, and you have to park those in front of the calcium. The entire balloon doesn't cause lithotripsy. Only these 2 emitters in the middle are the ones that give the shock.
Give it a few seconds. All right, and down to all the way. Okay, that's one inflation done.
So what do you expect to see while you're watching?
Okay.
Nothing.
See IVUS.
So you have to see by IVUS.
Yeah.
It's worth mentioning there's a new device coming out. I think it's not in the region yet. It's the RO device, which is like a microcatheter, basically. So it's easier to deliver, and it emits the same things. So in the future, we don't have to deal with this. We'll be dealing with microcatheter that will emit the ultrasonic waves and not a balloon, which basically is going to be much easier to deliver in places where you have significant stenosis.
Okay.
Off here. Okay, we're just going ahead. We just gave two bouts of therapy. We're going to give the third one right now. And you can see that the balloon is not too well expanded. Can you guys see that?
Yes.
Yeah.
Yep. So sometimes an indication of success would be the fact that, the balloon becomes well expanded during the process of lithotripsy. Let's go up again. Let's see if that opened up.
So what do you do if you don't get expansion? Rahman.
Well, you Sorry, go
We're
ahead.
not seeing expansion of the balloon.
You're not expecting this balloon to go high. You're just going at nominal pressure to deliver waves. The therapy is coming from the sonic waves that you send. So the balloon expansion to a higher limit is not something you're looking
Not
for
needed.
here. No, you just need to go to a nominal, and it's supposed to do its work by sending the waves. Again, you need to size properly to the size of the vessel. It doesn't make sense that you put a 2.5 and 5.0 because then the waves will have longer distance to travel, so you will not have the same effect.
I think that's a good point. The shock wave has to be sized 1-to-1. Otherwise, it's useless if it's not touching the walls. The other thing we learned a lot from Ziad Ali, I keep quoting him, is if you see the wire and the wire is asymmetric, closer to one wall than the other, that means you haven't broken the calcium completely yet. So what I would do is I would go just back and forth.
Which is what we're seeing right here, Dr. Waqar, I believe. Yeah. So I'm agreeing with all of you guys. That's a great discussion, and I'm going to exchange it right now for the trio. I was just doubting if it may or may not go because of the proximal calcification, but alhamdulillah, we're able to get there, get some therapies done. We're able to do a total of 5 bouts of lithotripsy. We're going to go ahead now with the 3O balloon. Hopefully that will get us more calcium cracking and open up the vessel better.
So this is what we do normally after the, yes, go ahead.
Excuse me. I think for the shock wave, you might need to go more cycles because here you go for only maybe 1 or 2 cycles at the area where the highest burden of calcium is. So you can go to more cycles until you see your balloon inflate. On the 2.5 is small also, but maybe more cycles since you are in already. So I'll do that. Sometimes also you can do with NC balloon initially, like 0.9 to 1, to see what is the area of the maximum, resistant for your inflation. Then you can focus on it later with the IVL.
How much remain with this balloon? How much you've already emitted?
I did 5 sets. I gave 5 bouts. Yeah. So we had 7 left. Yeah, I thought we were wasting time with the undersizing, so I went ahead to go with the 3.0. So I'm going to go for the 3.0, and I'll use them all 120 if I need.
And Mohammed and Ismail. So from beginning, you go which size? If you were the, retrospectively, of course, we'll learn from what you go bigger balloon or go same balloon. Anyone? So
I mean, we have seen it in the IVUS images. So it was like 2.2, 2.5. The circumference, the diameter at the whole area. So 2.5 was a good size to start with. Now upsizing to 3.0 is also appropriate, just to see what's the effect.
I agree. I think I would go with the 2.5 first, deliver the shocks. Maybe before upsizing to a 3.0 shockwave balloon, I would use a 3.0 NC balloon and see if I have good expansion. If I have good expansion at that point, or you see you can redo the IVUS again, see if you've achieved cracking the calcium, then maybe you don't need any more modification.
So going with NC balloon without knowing you've done a crack, is that a good idea, or you need to do the IVUS then go with NC? NC only stretch you the.
Usually when the sizing, I go to the distal diameter rather than the lesion for the sizing. So maybe if you go a little bit distal with IVUS, you'll see the real size of the LAD, and then you'll base your sizing based on that distal diameter. I think the lesion, this is maybe negatively remodeled and smaller, but even angiographically, the LAD is bigger than.
So this is the balloon, NC balloon, yeah?
No.
No, this is the shock.
This is the
3.0.
3.0, sure.
I think, Omar, what I would do is, once you have done this, just move the balloon back and forth a little bit to cover the entire area, because your area of calcium is a very short area. So make sure the emitter goes exactly where that tight area is.
Yeah, correct. I'm trying. You see, you can see what you mentioned earlier, which is the wire being on one side of the balloon rather than being straight in the middle. So I think that area still has some calcium that hasn't given in. I still have another 10 cycles to do, so I'm going to work on this a little bit more and then move it more proximal and more distal, like you mentioned. My plan is to do the whole thing. Yes.
Just a query. This is low pressure, صح? It's 4 atmospheres.
Yes.
Why do we go 2.5
Correct.
and then 3.0, double the cost? Could we not have just gone 3.0, low atmospheres? It's not going to damage a calcified vessel. So I think I would have gone 3-0 from the get-go, but I don't have experience, so. Yeah.
I would do the same. It just might be more difficult to deliver that 3-0 because of the size of the vessel already. So it's bulkier balloon. So I would normally balloon just the non-compliant balloon first, try to open it, and then we'll use the size based on the distal reference vessel or something in between. But in this situation, they chose to go with 2.5, which would be able to cross compared to 3.0.
Okay. There is a progress. Takes time.
Yeah, a
You have
little
to be
progress,
patient.
but not as much as I'd like to see. I'm going to pull back a bit more proximal, and we're going to crack the more proximal calcium as well. I
Remember,
just
this
pulled
is
it
the
back.
area
I've
we are
given,
not sure is contributing to patient, we are different here. This need to be done medically or
Right.
intervention. That's why you need to do the lesion properly.
Sure.
That's why spending time and being patient. Maybe we'll finish with something nice at the end. Any comments from panelists? Anything on what you do differ than this?
No, I think it depends also what's available for you. Like we tend to go with cutting balloon first in those situations, try to crack it first, and then based on the assessment, we will decide to go with the lithotripsy. This is just a cost-effective approach rather than evidence-based. That's what we do. And then I think based on the finding, eventually decide stent or DCB. I think that's important. Is like, when you deal with this calcium, then the question becomes, okay, we should not consider DCB. But remember, DCB has been also used in patients with CTO, complete CTO that has been opened. And if you have a residual less than 30, no significant dissection, you still can use DCB in those patients.
Yeah, on a small trials, there's no even actually when you prepare the lesion.
okay.
Calcium, by the way, it's whether a stent, anything you do is long term is not that good. So modifying with the devices you have, DCB in a small studies showed non-inferiority, even sometimes better.
6.
Just sometimes with the balloon, you can see the waist at the beginning, but at the end of the pulses you deliver, maybe the balloon will be much more expanded. So still maybe there is some little bit waste.
And remember, this is not a high-pressure balloon. It may induce enough cracks so you can use your NC or cutting balloon that will expand this. You just need the cracks to start.
Often we get the shocotopics, that is VPCs, ventricular premature complexes, when we are doing the IVL. So panelists, anybody, is there any criteria that we should stop, when to stop? Because it can precipitate VT and VF. So when we are doing the IVL, if they show the hemodynamics, we will get these ectopics, the IVL-induced VPCs. So often we get that. So is it to stop, when to stop, or you just continue, don't worry about those or ignore?
You see them a lot, and usually they don't mean much. There are, I think, only 2 reports in Twitter of VT induced for this, but thousands of cases have been done, and we haven't seen.
Push it in further a bit, I think. Okay. Yes, okay. So I'm not sure if you guys just saw the angiogram we got. Basically, it looks like angiographic was better. And so I'm just going to go a bit more distal. That area seems to have opened up or given in angiographically at least.
I think it's IVL,
and I'm going to
IVL
finish.
teach you to be patient. And it really goes with DCB. If you want to use DCB, you have to be very patient. I'm not talking about IVL, but IVL, how long are you spending here? Please spend it with a device.
I totally agree. I think DCB, if you may allow me, I think one of the important things about DCB is patience. You really need to prep the lesion very well because at the end of the day, the DCB is just delivering drug. So you should get pretty much the result you want to get before you deliver the balloon. So it does take time and it does need patience.
Patient is okay, yeah?
Yeah, doing very well. No issues, hemodynamically stable, asymptomatic.
Obviously,
And we got two
hemodynamic
more sets. So we're going to go ahead. Yeah, hemodynamic is doing very well. I'm not sure if you're able to see the hemodynamics on the screen.
So patient, you already loaded patient with what? What antiplatelet?
He's been loaded on aspirin and Plavix, dual antiplatelet aspirin and Plavix since yesterday.
Yeah. Was that pre-cath?
Yes, pre-cath from yesterday actually.
I mean, after the decision was to proceed for PCI, I mean, all these cases, we discussed them in a heart team meeting, and surgeons are part of this discussion. Sometimes if we want really short duration of dual antiplatelet, or the patient are really, they don't want to start dialysis, we referred some of them for cabbage, and they did a cabbage, and then they got the transplant. So all these are, as long as heart team discussion is being done, then we should be fine. Yeah.
You don't have this ultra fast antiplatelets available, no? The Cangrelor in your place?
Cangrelor.
No?
Unfortunately, no, we do not. Yeah, we do not.
Very nice for NC and DCB. طيب. You see how patient, everyone's relaxed.
All right, we're done with oral 120.
We want to see after the NC.
All right, let's see. Well, yes, let's see what happens. We're going to take a guiding shot here. Okay, let's go ahead and get an angiogram. Bismillah. Let's see what we get. Okay.
Good result.
So I think it's a reasonable angiographic result. What do you guys think?
Beautiful. For me, it looks very beautiful.
I think, Omer,
Yes, I think it's better than before.
Your plan either to post-dilate or just do NC balloon and then IVUS, or you could just IVUS. I think for the sake of time, I would just do NC balloon and then IVUS.
NC balloon will be a good idea.
Yeah, I think the NC balloon would be a good idea. And then I think what we can do is we can always deliver the drug. It won't harm to IVUS even after the delivery of the drug.
Yes.
I know time is catching up on us. So what I'll do is I'll do the non-compliant balloon inflation, and then I'll go ahead and do the DCB deployment. And then we can talk about IVUS or further imaging. I'm not sure that IVUS is going to add much. I think if we're going to do anything, maybe do a FFR to see if there's any reduction in the overall.
So the outcome of
no,
DCB
we'll need the
will depend on
3ONC.
Last preparation. Whatever you end, before you paint your artery, that will determine your future DCB effect. So we want to see that one after your NC or whatever you're going to use now.
Correct. I'm going to go for the NC, 3ONC.
So we'll show you the native one. No, we are not much interested in instant. I think that will. It's okay. You can do that to yourself later on, but we can watch this one, the native one. Only remain, I think, 13 minutes.
Inshallah, we'll try to get this done as soon as possible, deliver the drug, and maybe we can proceed with the, maybe I think we can proceed with the OM and then try to do that because it's an interesting osteal lesion. I was hoping to get some more discussion on that one. But we'll try to get them done right away, and we'll leave the IVUS later on. All right, this is our NC balloon. We'll start here.
What size?
3O.
That based on IVUS, yes?
Yes, correct. 3O by 16. So go up to nominal 12.
Go ahead with your question.
14, 16.
How long will you wait for recoil
18.
effect before going for a DCB? And the other question,
18.
do you
Let's see.
depend much on physiologic assessment rather than intravascular assessment alone for a DCB result before going for DCB or not?
Okay.
The recoil time,
Come down.
the use of FFR or DFR before you.
Yeah, we'll watch
to 20.
the NC now.
We'll do one more.
See how things are.
So we did a NC balloon inflation up to 18 atmospheres. We're going to go up to 20 atmospheres right now for 30 seconds. Okay,
20 seconds.
All right, so we see that area kind of a little bit open up compared to the previous situation we had with the lithotripsy balloon. The wire is now in the middle of the balloon. That area of plaque seems to have given in, which is nice to see. And I think we're ready to deploy the balloon. Okay, let's get a 3030.
What's the pressure?
So it went up to 20 atmospheres for 30 seconds. We'll take one more angiogram here before we deploy the balloon to make sure that everything is kosher. We don't have any flow limiting dissections, and make sure that we don't have any issues with, visible dissections or flow.
So what you want to see after the balloon is the TIMI-3 stenosis less than 30, ideally less than 20, and patient remain comfortable, and you are, and the ECG looks okay. Let's see that one.
Okay, ready? Okay, so that's our result. I think it looks more acceptable than what we had earlier, and I'm going to go ahead and just do the DCB deployment right now.
So hopefully by this maneuver you did, you created some micro dissection, which now I think ready to paint it. Agree?
Correct.
All agree? Who disagree? Please stand up. Okay, we are happy. Tell us what.
Okay, good.
What size and what length?
So we have we're having a 30 by 25. I think we're out of the 30s. We do use quite a few of the DCBs here in our cath lab. So
we're even with
we
5
have
minutes, inshallah, we can see everything. So now
Yeah,
the
inshallah,
whole
hopefully.
idea to handle things properly and to deliver it within 1 minute.
Okay.
And then
Let
take
me just.
different views so you'll be happy. Spend like 30 seconds to
All
1
right.
minute.
All right. We'll just do that. Hopefully get that done with. Okay, so this is a shorter. We'll use another one more proximal. You do this one here. Go up. Let's go up here. We're gonna go up to nominal pressure of 8. And the good thing is about the DCBs, you can always
what balloon using here,
go a little
doctor?
bit beyond.
What
I'm using the
balloon?
Prevail balloon, from Medtronic, which is a paclitaxel eluting, paclitaxel coated balloon.
Prevail.
So we'll do 1 minute if we can, and then after that we'll do another one. Do you have another one?
So I have a
Can
question.
you take another
Video,
view
yeah.
just while it's inflated? Take another view.
20.
So why paclitaxel? Why are we not using
15.
Alamus, Sirolimus, or Everolimus in DCB?
Yeah. I think the question is why not using the latest one available, more data with
No,
it?
do 25.
Yeah.
The solution, why not using the solution? Sirolimus, which data now available, and using this one. This is a question by Abdurrahman, and he tries to cause a problem.
So the good thing about paclitaxel is lipophilic. So it gets absorbed really quickly at the vascular level. But as you mentioned, once you create those cracks, then the absorption of the drug is really quickly.
Yeah, so the other solution, so paclitaxel is the only one with high lipophilicity, so it attached to the balloon very well and diffuse fast. So the other solution, when they tried the sirolimus, the solution, and the other ones, they had difficulty retaining it into balloon, and it takes longer time to come off, so you have to actually inflate the balloon for a longer period. So it was not practical until now. There is a new version coming out where they created reservoirs. So within the balloon itself, there is pockets of specific solution where when you touch it, it's supposed to burst and release it faster if you want to use something apart from paclitaxel. But it's still, paclitaxel is the main one to use for now.
So this is now the balloon?
Yes, this is a second balloon. We've deployed one drug-coated balloon in the more distal portion, and we're going to do this one in the more proximal portion with a little bit of overlap just to make sure that we got it covered.
Using 2 DCBs?
I think I just wanted, I used 2 because we didn't have enough length to cover.
With a longer one
because we didn't have I think it would exceed 30 millimeters. I think the length we're trying to cover is going to exceed 30 millimeters either way. So that's the longest that exists, the scope here. So I don't think we could have had one that could cover the whole thing.
Can we see the...
Is it different size or the same size?
3O, same size.
3O. Okay.
Yeah, yeah.
Yeah, I think Prevail have to up to
40. Yeah, up to 40.
40. They have it.
Yeah.
Oh, they need to get us at 40. We haven't seen it yet. They give you special treatment, Abdurrahman, huh?
طبعا احنا that's fine. Can you see it well? Yeah.
Okay.
So
What
just,
I do,
yeah.
I just go, spend some. I get irritated. I want to see it in different views while I'm waiting, because sometimes people are not waiting 30 seconds too much or 1 minute. Dr. Abdurrahman.
So just a quick point about the application itself. So the minimum time required based on bench studies is 10 seconds. So you need at least 10 seconds, because if you do something in the ostial LAD to the left main, you cannot stay up for long. So the minimum you need is at least 10 seconds. The study, however, is done minimum up to 60 minutes. So 40 seconds to 60 seconds, preferable more than that. But currently the practice is at least up to more than 40 seconds. So those technical point that's neglected. So if you do a left main, sometimes I've dipped the left main, and I've used it for about 10 seconds to 15 seconds, that situation.
I just wait until the blood pressure starts dipping down. That's when I stop.
Okay, can we?
All right, so this is our final shot after deploying the DCBs. So I think it's a reasonable result. We have one of two options. If because of time, we can, we're going to work on the OM, but I don't know that we're going to have enough time to.
There was a question
to do it together.
about whether we do a physiology post of this. I mean, you can do that as a part of your,
Correct.
research.
But just to prove the point,
benefit of
and
this, you will see it later on. The positive remodeling, all that. The acute, you want to see safety, you want to see the flow, and that's it.
Yeah.
So thank
Totally
you very much.
agree on that
Looks
one, yes.
beautiful to us. Huh? Everyone's happy, huh? Thank you, Doctor.
Thank you guys very much. Our pleasure to be with you. Thank you.
Thank you.
Any last comment from the panelists?
So what we need to accept in the drug-coated balloon area or aerial is probably not the usual result that we usually get after drug-eluting stents. We should accept maybe 10 to 30% of residual stenosis. That's within the acceptable limits. We don't have to have like 0% stenosis, residual stenosis. Otherwise, there is no dissection. It's an excellent result.
Excellent. So really, as I said from beginning, you all seen beautifully by Dr. Omer and Osama how patient, how calm they were, and doing the devices they're familiar with. When applied properly, you see the result as good as DS, I call it, at the start, but inshallah in future will be better. Patients, look at this patient at high risk of bleeding, high risk of operation issues, bleeding as well. You don't know, but in this way you are shorten their antiplatelets to the maximum. So thank you for your interactions. Thank you to the panelists. Thank you to the operators. Thank you very much.
Thank you. Thank you, everybody.